A very good evening to one and all. A very warm welcome to all the participants and our speaker for today, Dr. PIYUSH GUPTA sir. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D community. I am thankful to all the participants all over the country who have taken out time and have joined us for this evening talk. Pharm D community has been created with the charter to just a second. I'm so sorry for that. Pharm D community has been created with the charter to provide free webinars by eminent doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate, and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible with the help of my teammates. Thank you, everybody, for it. I'm thankful to our speaker, Dr. PIYUSH GUPTA sir, who actually accepted our invitation during such tough times of COVID-19 and took out time to deliver this lecture. I would also like to tell about our next lecture, which is on 30th August. The registration link will be sent in the chat box in the later half of the lecture. I would like to hand over the session to Yamini for the introduction of our speaker. Handing over it to Yamini. Thank you.
Thank you, Aishwarya. I once again welcome all the participants to this webinar. We are glad to have today with us Dr. PIYUSH GUPTA sir as the speaker for a webinar on hepatitis B and C. Know it, confront it. A very warm welcome, sir.
Thank you.
Dr. PIYUSH GUPTA sir, just a second. Dr. PIYUSH GUPTA sir has done his M.D Medicine and D.M in Gastroenterology from CMC Vellore, India. Sir has done his fellowship in Advanced GI Endoscopy from CMC Vellore, India. Sir is currently working as consultant gastroenterologist and interventional endoscopist at Rajiv Gandhi Cancer Institute and Research Center at New Delhi in India. Sir has received various awards for oral paper presentation at conferences in Hong Kong, Chennai, and New Delhi. Sir has also been awarded with the Best Presidential Poster Award in INASL 2017 at New Delhi, India. Sir is a member of Indian Society of Gastroenterology, Society of Gastrointestinal Endoscopy of India, and Indian National Association for Study of Liver. Sir has also published articles in various national and international journals which are peer-reviewed. With this brief introduction, I now hand over this session to Sir. Please take over, sir.
Okay. Can you guys see the screen?
Yes, sir.
Okay. First, we'll be discussing about hepatitis C. We should know it and how to confront it. Okay. So, this is the structure of hepatitis C virus. Okay, we should understand that it is a RNA virus, and the RNA has structural component and non-structural protein component. Okay, the structural component include core, E1 and E2 proteins, where non-structural include various enzymes. Okay, which I'll be discussing in the next slide. Now, this is the short life cycle of HCV. Now, first of all, when the HCV virus enters the body, it goes into the cells, hepatocytes specifically. There are endocytos there where the uncoating occurs. Okay, when the uncoating occurs, the RNA is released into the cytoplasm, which is processed by endocytosal reticulum, and where the translation occurs, various proteins are synthesized. In the Golgi apparatus, the assembly and maturation occurs, and it is released back into the blood. Now, HCV causes various changes into the hepatocytes. Okay, it can be via direct mechanisms or indirect mechanisms. Okay, so the direct mechanisms include direct action by the viral proteins and which activate many pathways into the cells. Whereas indirect mechanisms mostly point to mitochondrial dysregulation, which causes insulin resistance and steatosis as well as inflammation. The endpoint is activation of hepatic stellate cells and immune system, which causes eventually fibrosis, cirrhosis, and may in some patients turn up as hepatocellular carcinoma. Now, which people should we test? Now, people with risk behavior such as who abuse IV drugs, intranasal illicit drug use, men who have sex with men, these are the behaviors, risk behaviors, and we should test such patients. Okay, risk exposures are patients on long-term hemodialysis, patients, medical personnel, maybe healthcare, emergency, medical staff, public safety workers, who have a needle stick injury or a sharp exposure or a mucosal exposure to HCV infected blood. Children born to HCV infected women, people who receive blood from a donor who later tested positive for HCV. These are the exposures which are risky and can cause hepatitis C infection. Other conditions like HIV infection, unexplained chronic liver diseases, or most patients come with increased elevated ALT. People with solid organ donors or transplant recipients. Okay, these patients should be tested. Now, acute HCV infection occurs. Mostly it goes asymptomatic. People can have mild symptoms. Okay, and most commonly, like 55 to 90% of these patients develop chronic hepatitis C infection. 2 to 24% over 2 decades can finally have cirrhosis of the liver. 3% per year there is a chance of decompensation, and 1 to 4% chance there is a risk of developing hepatocellular carcinoma. Now, this is the time after exposure, what happens in the body exactly. So when you are exposed to hepatitis C virus, it may be a symptomatic exposure or you can be asymptomatic as well. The HCV RNA increases in the body. As we have discussed the life cycle, it keeps on getting processed and generated in the body. The serum ALT levels, initially they rise because of the inflammation, and then they eventually subside. Body gets used to it. And during that time, anti-HCV rises. As we can see in this cartoon, that over 3 to 6 months it takes for the anti-HCV antibodies to HCV antibodies to develop. During this time, HCV RNA can be detected. So you should keep in mind that it takes 3 to 6 months for anti-HCV to become positive in a person who is acutely infected with HCV RNA virus. Now, what are the factors associated with accelerated fibrosis progression? Now, it can be host factors or viral factors. Now, viral factors can be genotype 3 virus, which is more prone to accelerated fibrosis, or if there is associated infection with hepatitis B or HIV. Now, host factors can be modifiable, like alcohol consumption. We can decrease alcohol consumption easily. Non-alcoholic fatty liver disease, weight reduction can have improvement in that. Obesity, again, weight reduction required. Insulin resistance, again, weight reduction required. Non-modifiable factors include fibrosis stage. If it is a high stage fibrosis, we can do nothing about it. High-grade inflammation, again, nothing can be done. Older age, male, and patients with transplant recipients. Okay. Now, not only hepatic, in fact, HCV can have many extrahepatic manifestations. It can be a proven manifestations are autoimmune thyroiditis, B-cell non-Hodgkin lymphoma, lichen planus, cryoglobulinemia, monoclonal gammopathies, porphyria cutaneous tarda. Other conditions which are possibly linked to hepatitis C virus include chronic polyarthritis, diabetes, pulmonary fibrosis, nephropathies which are non-cryoglobulinemic, thyroid cancer, renal cell cancer, and vitiligo. Now, when a patient comes with HCV, and first test to be done is HCV antibody testing. If it is non-reactive, then most likely you do not have any HCV virus, no further testing is required. If the HCV antibodies is reactive, then the next test is HCV RNA. It is a quantitative test. If it is detected, you probably are suffering from a acute or chronic HCV infection, and treatment is recommended. If HCV RNA is not detected, that signifies that there is no current infection. So we just need to follow up and monitor. No need for treatment in that scenario. Now, what is the goal of treatment for HCV? It is to reduce all-cause mortality and liver-related health adverse consequences. Now, how do we do that? Now, if we can detect HCV as early as there is no liver fibrosis, no or minimal liver fibrosis, that is called F0, F1. So 15-year survival rate in patients who have experienced SVR. SVR means sustained virological response, which is calculated 12 weeks after the treatment is over. If the virus is negative, that is termed as SVR, sustained virological response achieved. If they don't, HCV is still positive after 12 weeks of treatment, then it is called a treatment failed and untreated patients. So 15-year survival rate in patients who achieved SVR was 93%, whereas those who failed treatment with the drugs was 82%, and those who were not treated was 88%. Okay, this was statistically significant. So even at an early stage, when person has not developed any liver fibrosis, then also treatment is indicated because the survival rate depends on it. Suppose a patient has advanced liver disease. So people have seen that patient who had achieved SVR, that is virus is not detectable anymore, and who had not achieved SVR. So the transplant requirement, the liver morbidity and mortality, and HCC, all three were decreased in patients who had achieved SVR. So even in advanced liver disease, the treatment is important. Having said that, patients who have advanced liver disease, because they had already developed cirrhosis, so follow-up is routine follow-up like cirrhosis we do for each patient is recommended. You need not stop the follow-up because HCV is cured, that doesn't mean that liver will completely recover. There is a good chance it may recover, but not completely. So follow-up is recommended. Even HCC surveillance is recommended. Just I want to tell you a brief thing about fibrosis. How do we assess liver fibrosis? Liver fibrosis injuries can be assessed in primary healthcare settings by examination. If we find ascites, patient has GI bleed, these suggest patient has full-blown cirrhosis, which is decompensated. If the patient's LFTs are deranged or serum hyaluronate, which indicates biochemical marker for fibrosis, which we can do. APRA, that is AST platelet ratio index. So these things and other simple tests can determine that fibrosis is there or not in the liver. In secondary healthcare center, we have facilities of ultrasound, fibroscans, and some serum markers, algorithm like FIB4, etc. Plus minus liver biopsy can tell us about the grade of fibrosis. In tertiary healthcare center, we have fibroscans, RFE, MR elastography, even HVPG can sometimes help, liver biopsy, which is outdated nowadays, but these things help in determining the stage of fibrosis and inflammation. A word about fibroscan. We hear so many people that patient has undergone a fibroscan, but people don't know how to read a fibroscan. Okay, suppose you get a fibroscan report, you just have to see a value called stiffness kilopascals, which is marked as an arrow. Okay, so it is 3.9 in this current report. If it is less than 7, just be reassured that patient has F0 to F1 fibrosis. Okay, it is the minimal stage. Okay, and that at least 10 shots we take, and the success rate of more than 60% to be sure that this result is accurate. Now the liver stiffness cutoffs in chronic liver disease, we can just roughly say that value below 7 determines F0 to F1 fibrosis when compared to an actual liver biopsy. Value more than 12.5 suggests F4 fibrosis, that is cirrhosis, when compared to a liver biopsy. Now the values between 7 and 12.5 like F2 and F3 based on Metavir score, they correlate, but they are not very precise. Okay, liver biopsy is the ideal gold standard. So F2, F3 is a moderate or intermediate thing, and we cannot be very sure that it is based on fibroscans that it is F2 or F3. Okay, they're like intermediate values. Now, various infections like hepatitis B, HCV, HIV, hepatitis C, chronic cholestatic liver diseases, alcohol, and NAFLD. These have various different cutoffs. Not all cutoffs are not same. So roughly you can say 7 and 12.5. Now, a patient comes with HCV and we have diagnosed him as chronic hepatitis C. What should we do next? So within 6 months of starting antiviral therapy, DAM is direct acting antivirals. CBC, INR, LFT, creatinine, fibrosis assessment, hepatitis B, and HIV has to be checked for each patient. And immediately prior to starting antivirals, we have to look for quantitative HCV RNA. And if we are not, patient is not intended for starting a pan-genotypic regimen, in that case, genotype may be required. Okay, so genotype is not required nowadays in each patient. Earlier, we used to do for each and every patient, but nowadays, quantitative HCV RNA is more than enough. Now, the safety of direct-acting antiviral regimens in humans has not been established during pregnancy and for nursing mothers. So, those come as special cases and require counseling. Now, HCV RNA is composed of part which determines the structural proteins, that is core, E1 and E2, and non-structural proteins, which mostly are enzymes. So the first thing is NS3, NS4A. Okay, you have to understand this thing, that this is HCV polyprotein. These enzymes cause HCV polyprotein cleavage. So this could be one mechanism of action which we can target, and we have developed acting the antivirals based on this called NS3, 4A protease inhibitors, which are a Previr class of drugs. So all these class of drugs will have a PREVIR, Previr at the end. Okay, like Elaprevir, Boceprevir, Simiprevir, and the list goes on. Okay, the important drugs in this nowadays use are Grazoprevir and Voxilaprevir. Okay. Now, second group of drugs is NS5A inhibitors, which are in NS5A is involved in formation of membranous web, replication, and virus assembly. Okay, so if we inhibit this part of the virus, so we can actually stop the virus replication and virus division, so that we can cure HCV in that cases. So those classes of drugs are called, have an asvir at the end, like Decletasvir, Ledipasvir, Velpatasvir, Elbasvir. Okay, and the last class of drugs which is nowadays used is RNA-dependent RNA polymerase inhibitors, that is NS5B polymerase inhibitors. They can be nucleoside or non-nucleoside inhibitors. Okay, nucleoside inhibitors are sofosbuvir, and non-nucleoside are dasabuvir, etc. Now, this is the diagrammatic picture of the same mechanism of action of different class of drugs. As we can see that NS3, 4 protease inhibitors act to inhibit initial stages of the virus replication, whereas the polymerase inhibitors and NS5A inhibitors affect the later stages. Okay. Now, what people are not eligible for simplified treatment, which I'll be discussing in the next slides, like patients with prior hepatitis C treatment who have failed the treatment, patient with cirrhosis, I will be discussing in detail what's treatment to be given for those patients, patient with end-stage renal diseases, especially who are on hemodialysis, patient with HIV, HbA/Cg positive patients which are co-infected with HCV, patients females who are currently pregnant, or known or patients having known or suspected hepatocellular carcinoma, or prior liver transplantation done in those. So these are special category of patients in which the treatment which I will be discussing is not valid. Now, pan-genotypic regimens. Pan-genotypic regimens means that if patient is HCV positive and RNA is also positive, it is quantifiable. In that case, whatever the genotype, you can give Glecaprevir and Pibrentasvir, which has to be taken with food for a duration of 8 weeks. Okay. Now, the second drug is Sofosbuvir and Velpatasvir. It has to be given for a duration of 12 weeks. It is valid for genotype 1, 2, 4, 5, 6, but not valid for genotype 3 patients. Genotype 3 patients, there is special resistance in those patients, like called Y93H resistance. If that patient virus is having that mutation, then this regimen doesn't work well in those patients. Okay, so we need to check for that resistance in genotype 3 patients. Now, this is the treatment for genotype 1A patients who have not received any prior treatment for hepatitis C and do not have cirrhosis either. The cirrhosis is determined on the basis of fibroscan report or liver biopsy or any biochemical marker for fibrosis. Okay, so daily fixed combination of Elbasvir, Grazoprevir can be given without baseline RAS testing for Elbasvir. RAS I will be discussing in detail in coming slides. See, in India, we do not have Elbasvir, Grazoprevir, Glecaprevir, or Pibrentasvir. We have Ledipasvir and Sofosbuvir. So for our country, the valid regimens are Ledipasvir and Sofosbuvir combination for 12 weeks, and Sofosbuvir and Velpatasvir combination for 12 weeks. Okay, these two are valid regimens in our country for genotype 1A patients. Patients who have compensated cirrhosis means patients who have not developed any GI bleed yet because of viruses, or who have not developed any ascites because of cirrhosis per se. So those people are considered as compensated cirrhosis. They have not even developed any encephalopathy. So these people can be treated with sofosbuvir and ledipasvir, and sofosbuvir and velpatasvir. The other two combination drugs like elbasvir, grazoprevir, and glica and pibetasvir, they're not available in India as of now. Treatment naive patients with genotype 1B who do not have cirrhosis, the treatment is more or less same for both genotypes, like in our country, especially now. Ledipasvir and sofosbuvir for 12 weeks, or sofosbuvir and velpatasvir for 12 weeks. Now, patients with genotype 1B and compensated cirrhosis, treatment is again same. There is no change. Patient with genotype 2 without cirrhosis, for our country, since glicaprevir and pibetasvir is not available, so sofos and velpatasvir for 12 weeks is enough. Again, patients with genotype 2 who have cirrhosis, treatment is again sofosbuvir and velpatasvir for 12 weeks. Now, genotype 3 patients who without cirrhosis, same sofos and velpatasvir for 12 weeks. Genotype 3 patients with cirrhosis, again sofosbuvir and velpatasvir for 12 weeks without any prior mutation with NS5A RAS Y93H for velpatasvir. Okay, so in cirrhosis, we have to look for this mutation, or patients who have already received treatment, we have to look for this mutation before giving sofos and velpatasvir. Patient without cirrhosis, you can directly give sofosbuvir and velpatasvir. There is no worry regarding that. Patient with genotype 4 without cirrhosis, we have both options. Genotype 4, 5, and 6, this treatment goal is similar to more or less genotype 1. So ledipasvir, sofosbuvir, or sofosbuvir, velpatasvir, both are equally good. Again, same, we can give ledipasvir, sofosbuvir, or sofosbuvir, velpatasvir for 12 weeks in patients with genotype 4 and compensated cirrhosis. 5 and 6, again, sof, velpa, and ledipasvir, sofosbuvir for our country. This is also the same as we have discussed before. Now, patients with decompensated cirrhosis who have genotype 1 and 6, any genotype, as in pan-genotypic decompensated cirrhosis, who are ribavirin eligible, they can be given a fixed dose combination of ledipasvir, sofosbuvir with low initial dose of ribavirin, which can be increased as tolerated. Okay. Daily fixed combination of sofosbuvir and velpatasvir with weight-based ribavirin for 12 weeks is good enough for them who are decompensated cirrhosis. As I have already told, decompensated cirrhosis means patients who have GI bleed, who have ascites or encephalopathy. Patients with decompensated cirrhosis who we cannot give ribavirin because ribavirin is associated with so many diseases. Patients who have neurological disorders, patients who have immune-mediated disorders, patients who have severe anemia, say patients, females who are in childbearing age group, they're all considered as ribavirin ineligible. So these patients, we can give sofosbuvir velpatasvir for 24 weeks. As we have seen in previous slide, that if we are giving with ribavirin, 12 weeks treatment is enough. If we are giving without ribavirin, 24 weeks treatment is required for sofos and velpatasvir. But for ledipasvir and sofosbuvir, 24 weeks again. Okay. Now, patients who are treatment naive or interferon experienced children and adolescents without cirrhosis or with compensated cirrhosis, that means we are talking about children and adolescent people now. They can be given ledipasvir and sofosbuvir weight-based dosing for more than 3 years of children. Okay, for genotype 1, 4, 5, or 6 without cirrhosis or with compensated cirrhosis, if given for 12 weeks, should be enough. Okay, so for all practical purposes, other than genotype 3, 2, and 3, these genotypes can be treated with sofosbuvir and ledipasvir if the child is more than 3 years of age. That glicaprevir and pibetasvir mentioned above is not available in India for now, but it can be given more than 12 years, not less than 12. Now, in March 2020, that is a few months ago only, sofosbuvir and velpatasvir has been approved by FDA for children more than 6 years, more than equal to 6 years of age, and more than equal to 17 kgs. Okay, if the child does not meet any of this criteria, he has to be. We have to wait till he becomes more than 6 years or becomes more than 17 kgs to be considered for sofosbuvir and velpatasvir. If the child has achieved this age, it is a pan-genotypic regimen, as I have already discussed. For 17 to 30 kgs, we can give half a tablet of each, that is sofosbuvir 200 milligram and 50 milligram velpatasvir. Normal doses are 400 for sofosbuvir and 100 milligram for velpatasvir. If the child is more than 30 kgs, then a full dose is enough. If the treatment duration for treatment naive and treatment experienced liver transplant recipients without cirrhosis or with compensatory cirrhosis is 12 weeks. And if a child has decompensated cirrhosis, then ribavirin has to be added for 12 weeks. Now coming on to HCV and HIV co-infection, I have just jotted down the important points which need to be remembered, that antiviral treatment need not be stopped just because patient has to be given HCV therapy, and ART has to be continued in each and every patient. Now, elbasvir, grazoprevir should not be used with cobicetat, efavirenz, etravirine, nevirapine, and any HIV protease inhibitors. This elbasvir, grazoprevir not available in India. Glecaprevir and pibrentasvir not available in India. So I'll talk about sofosbuvir, velpatasvir, which should not be used with efavirenz, etravirine, and nevirapine. If patient is getting that, we might have to change the drug to be, if we want to give sofosbuvir and velpatasvir. If suppose we are planning to give sofosbuvir, velpatasvir, and voxilaprevir, they should not be used with above mentioned drugs plus ritonavir based regimens. If sofosbuvir based regimen should not be used with tipranavir, and ribavirin should not be used with didanosine, stavudine, and zidovudine. So these drug interactions which we have are the things which we have to keep in mind before giving HCV therapy to an HIV positive patient on ART. Now, if patients is a hemodialysis patient, CKD, end-stage renal disease. So lately, after doing so much of research over the last couple of years, this has been going on in our country and in all other countries for so long, and people have found that there is no dose adjustment in direct-acting antivirals is required in the recommended regimens which we have discussed. Now, I want to just take note that that patients who are diabetic, they have a potential of symptomatic hypoglycemia when we are giving HCV therapy. So, on treatment and post-treatment monitoring for hypoglycemia is recommended in diabetic patients. Patients who are on warfarin, since we can't stop these drugs, they have a potential for changes in their anticoagulation status. So, we need to monitor it closely. At least every 2 weeks, it has to be monitored. Patients who develop ALT more than 10 times during the therapy with direct-acting antivirals in HCV with symptoms of signs or symptoms for liver inflammation that or increasing bilirubin or alkaline phosphatase or INR, then this therapy has to be discontinued for some time because patient is going into liver failure. An increase in ALT which is not more than 10 times, it is less than 10, but patient is typically symptomatic for liver failure. That is, patient having weakness, nausea, vomiting, jaundice, and along with raised bilirubin, alkaline phosphatase or INR, they also warrant stopping of direct-acting antivirals in view of patient going into liver failure. Now, I want to discuss about resistance. Okay. Now, HCV resistance, that is polymorphism of substitution, means there is a difference in amino acid at a defined position. Okay. RAS is termed as resistance associated substitutions. Any amino acid change associated with reduced susceptibility to a virus to one or more antiviral drugs. Okay, so if this different mutation, that is the difference in amino acid at a defined position, is affecting the therapy, that is, viruses become resistant, they're getting resistance to a drug, then it is called resistance associated substitutions, RAS. Now, it can be a class specific drug, that is, it can be a whole set of Previrs can be prone to it, or whole set of polymerase inhibitors can be prone to it, like Duvids, or whole set of NS5A, like Asvirs, are prone to it. So it can be a class RAS, class specific in resistance, or a drug specific resistance, that only one particular drug is resistant, other drugs in that same class can be given. Okay. So commonly, elbasvir and grazoprevir, we recommend that genotype 1A infected people have to be checked for elbasvir grazoprevir specific RAS before giving this regimen. In ledipasvir and sofosbuvir based regimens, in genotype 1A patients who are infected, who are treatment experienced, in those cases we can consider checking for RAS, but initial treatment naive patients, we can give sofosbuvir ledipasvir without checking for any RAS resistance associated substitutions. In sofosbuvir velpatasvir, as I already discussed, In genotype 3 patients, it is recommended that we check for RAS in genotype 3 patients with if patient is having cirrhosis or is already treatment experienced. But if patient is treatment naive, has received no treatment, then without checking for mutation, we can give sofosbuvir and velpatasvir. Coming on to HBV and HCV co-infection. Sometimes we find patients is suffering from both hepatitis B and hepatitis C. In such patients, hepatitis B, suppose patient is not taking any treatment for hepatitis B. He is not indicated by the guidelines to be treated for hepatitis B. We have two options. Either we can give prophylactic hepatitis B therapy, or we can just monitor hepatitis B DNA closely. And if they start worsening, then we can start the patient on hepatitis B related drugs. Okay. If we plan to give hepatitis B prophylactically to such patients while starting HCV therapy, then it has to be continued for 12 weeks after completion of therapy, and then it can be considered for stopping. Now, these are some of the drug interactions which have been noticed for with direct acting antivirals. Okay, LDV means ledipasvir, so S of F means sofosbuvir, EBR means elbasvir, grazoprevir, VEL is velpatasvir, SOF is sofosbuvir, glicravir, pibentasvir, sof, velpa, and voxilaprevir. Now, in general, we recommend that we do not give any other drugs to such patients. Even as simple as pantocid, we don't give to these patients because they have a potential for interaction. Okay. So when we are starting HCV therapy, avoid any other drug. Okay. These red marks means that we should not give the anti-HCV therapy while patient is on these drugs. Yellow marks means we have to closely monitor and maybe dose had to be adjusted. Green marks means that it is safe to give the drugs. Okay. Now, anticoagulant important. I'll just discuss the important drugs like anticoagulant and antiplatelet agents. In these set, there is no mention of any clopidogrel or ecosprin. So usually our patients are on clopidogrel and ecosprin. So we can easily, safely give anti-HCV therapy if the patients are on those sorts of drugs. If any of these drugs, as I have mentioned, then it has to be closely monitored or drugs has to be changed. If patient is on any anticonvulsant and these barbiturates, then it has to be taken into consideration that so many drugs which we give as anticonvulsant and barbiturate, which cannot be given with HCV therapy. Okay, we have to modify that. Antihypertensives which we routinely use, like calcium channel blockers or beta blockers, they can be easily given with HCV therapy. But telmisartan, which I have mentioned here, it has to be cautiously given in patients whom we are starting HCV therapy. Okay, and antiretrovirals I have already discussed what all to be avoided, and I think that other drugs we don't usually use quite often. So statins has to be stopped, or we have to closely monitor when we are starting HCV therapy. Okay, other heart failure agents, ambrisentan we can give. Loop diuretics, they are very safe. Okay, other drugs are more or less safe only. Antibiotics we have to in general avoid. Okay, especially rifamycin antimicrobials. Now, if patient is on immunosuppressive treatment and if patient is HCV positive and we have already treated that patient before, then there is no need to repeat HCV RNA unless we see that patient's LFT is getting worsened. Okay, there is no such recommendation that to see for HCV RNA reactivation in immunosuppressive patients who is already treated, okay, or has achieved SVR. Now, ribavirin-based regimens are contraindicated for pregnancy by both males and females. Means even the male partner should not be on ribavirin if his spouse is they're planning for a child. Now, suppose if sustained biological response is not achieved, okay, then retreatment for chronic HCV should be considered, and there are different set of regimens for that. I will not be going into that details in this session. Disease progression assessment, that is patient on cirrhosis, is he developing any more fibrosis, any decompensation, it has to be assessed as usual. Surveillance for HCC has to be done as usual, okay, and endoscopic surveillance for varices has to be done as based on the guidelines, existing guidelines, okay. This has to be done usually. Now, suppose there is a what to do when you are exposed to a hepatitis C positive patient and you get a needle prick from that patient, or there is a mucocutaneous exposure with the patient who is HCV positive. Okay, in that scenario, within first 48 hours, we have to do our hepatitis HCV antibody and HCV RNA, these two things. If we have no antibodies, that is, it is negative, and no RNA, RNA is also negative, then we are not suffering from any existing HCV infection. We have to repeat our testing after 6 months, because in my first slide I told that it takes almost 3 to 6 months for anti-HCV to develop. Initially, we can look for HCV RNA if need be. Okay. So if after 6 months, HCV RNA is still negative and antibodies are not there, then there is no HCV infection. Okay. If there is if HCV antibody is positive and RNA is negative, that means there is a prior resolved infection. Okay. So in that case, if we repeat the testing after 6 months and still there is RNA is negative, then there is no active HCV infection, nothing to worry about. If any of this is, if HCV RNA is positive during after 6 months, then then we have to go for treatment. Okay, there's no other option. If a medical person is HCV antibody negative, but RNA is positive, that means that even though patient has been exposed, but patient has acute HCV infection, which is already there. Okay. So in that case, HCV treatment directly has to be done. If a person is HCV antibody positive and HCV RNA is also positive, then patient already has a prior chronic infection. There is no change even after exposure. It is just incidentally detected. So that case, HCV treatment is recommended as per the guidelines we have discussed. Okay. Now we'll be discussing about hepatitis B. Now hepatitis B is a DNA virus. Okay. Now we have to understand the structure little carefully. It is not a complete DNA. Okay, we can see that small RNA stands separately. Okay, at the end of the virus, we can see there is a blue colored core. So that is a core antigen. Okay, we can see green colored spikes. That is an envelope, E antigen. Okay, and we can see a yellow colored thing. That is a HBsAg, S antigen. Okay. So you have to understand this is an S antigen, what is a core antigen and what is an E antigen. Okay. So when virus comes into the body, this core antigen is not directly exposed. Okay. So in blood, we'll never find any core antigen positive. We'll always find any antibodies against core antigen. We'll never find any HBsAg. It is always HBe antigen which is assessed, always HBsAg which is assessed, never any core antigen which is assessed. Only antibodies against core are assessed. Okay. So a small life cycle of hepatitis B. When hepatitis B virus is endocytosed into the hepatocyte, what happens is this virus the DNA part goes into the nucleus. Now this is quite different from hepatitis C. In hepatitis C, everything was happening into the cytoplasm only. So with the current treatment in hepatitis C, we were able to cure the people with hepatitis C. In hepatitis B, what happens is nucleus is involved. So DNA has to go into the nucleus where the DNA closed circular loop is formed. It is triple C DNA is completed and it is transcribed in the nucleus. That the RNA which comes out of the nucleus causes translation and protein formation. Okay. So this triple C DNA always stays in the nucleus. Okay. There is, till now, we have not developed any drug which can take care of that triple C DNA. Okay. This is the hepatitis B DNA in the nucleus. So that is why it is, till date, we are not able to cure people with hepatitis B. Okay. That easily. It is very difficult to cure a person with hepatitis B. It can be controlled with the medicine, but it is very difficult to cure a person with hepatitis B. Okay. Just because of this reason that triple C DNA lies in the nucleus. And we have not developed any antiviral against that. Now, again, hepatitis B can be transmitted by syringes, needles, as we've already discussed. Okay, sexual transmission, organ transplantation or tissue transplantation. From parent to child, it can be mother to baby, it can be transferred, and via blood transfusion, as it is similar to what we had discussed in hepatitis C. Now, how the natural history goes is, if a person develops an acute infection with hepatitis B, which can happen, then almost 90 to 95% people will have complete resolution, no remnant disease, and they'll be cured on their own. Okay, out of which this is quite different from hepatitis C. Hepatitis B, acute infection, almost up to 90% of the people were developing chronic hepatitis, whereas in hepatitis B, up to 90% they improve. Only 5 to 10% people develop chronic hepatitis. Okay. Now, this chronic hepatitis eventually around 20% of the people will develop cirrhosis, end up developing cirrhosis, eventually liver cancer or decompensated cirrhosis. Okay. This takes decades of time. Okay. Now, people with hepatitis can present as unexplained weight loss, fever, loss of appetite, abdominal pain, headache, and fatigue. They're very non-specific symptoms. It's difficult to detect that. Now, whenever HBV infection occurs, it can occur as either occult infection or acute infection, as already discussed, or a chronic infection. Okay, chronic infection means it can be from the birth, or patient had developed acute infection and later on went on to develop a chronic infection. Now, occult infection. This is a relatively a newer term. Okay, last couple of years only it has come up. Occult infection means we cannot detect HBsAg in those people. Okay, HBsAg, which is the main test to detect hepatitis B, is negative in people, but still they have hepatitis B. Why? Because that triple C DNA, that circular DNA which I was discussing, okay, that lies in the nucleus. Okay, and if that is there, even if the patient is HBsAg negative, he still has that hepatitis B infection. That is called an occult infection. It can be detected by either patient is anti-HBC positive, or in the tissue we get HBV DNA, or in the blood we get low levels of HBV DNA. These are the ways to determine occult infection. Okay. Now the chronic infection, they have 4 stages of chronic infection in a person. Okay, with hepatitis B. First stage is immune tolerant phase. Okay, this is the first stage in which a lot of virus is there in the body. Okay, and body does not mount an immune response. Okay, so all the antigens will be positive. That is, high DNA will be there, high serum antigen, HBe antigen, HBs antigen. ALT will be normal because there is no damage to the liver tissue. There is no immune reaction. There is no inflammation. Okay. Second phase is immune clearance phase. Okay, in which body starts mounting a immune reaction. Okay, in which DNA is still high, but it is lower than in initially immune tolerant phase. It is in billions. In immune clearance phase, it is in few millions to thousands. Okay, and there is hepatitis now. There is inflammation. E antigen is still positive because body is still trying to clear. Okay, and anti-HB is starting to form, but not yet formed. Okay, in inactive HBsAg carrier state, what happens is a good immune system has been created and HBV is suppressed. So there is low to undetectable HBV DNA. Body has successfully suppressed the hepatitis B virus, and there are no further antigens. HBe antigen is negative, and patient is seroconverted to anti-HBe. That is, we have formed antibodies against E antigen also. That is called a E seroconversion. Okay, and anti-HBs may be positive, okay, or may still be negative only. And ALT becomes normal because body has successfully suppressed the hepatitis B virus and injury which they were causing. Okay, so last thing, reactivation. Sometimes what happens is we get immunosuppressive drugs, or for some reason DNA levels again start increasing. Okay, we can have elevated ALT in that scenario, and E antigen can become, E antigen still is negative, but anti-HB E antigen is still positive. Okay, that is called a reactivation. Now this is the same thing, a little more diagrammatic. Initially, what first A means a person is having hepatitis B from childhood. Okay, in India, most common is parent-to-child transmission. Okay, so we have an immune tolerance phase which lasts till young adulthood. Okay, till maybe up to 30 years of age. Okay, it can last, immune tolerance phase. As we have already discussed, immune tolerance phase means a lot of viruses there. There is no liver injury and there is no immune response. Okay. Second comes the immune clearance phase, in which virus is not, the DNA is not in billions, but it is in millions. But body has started mounting the reaction, causing liver injury. ALT starts rising, HBe antigen is still positive. Antibodies are not yet formed. Third phase is inactive carrier stage. Again, anti-HBe starts forming. No antigens. DNA is very low. Okay. ALT is negative because body has successfully mounted a good response. Last stage is reactivation and liver transplantation. Okay. So as I discussed, the A is patient having infection from childhood, and B is later on in the life patient develops acute infection which goes on to form a chronic infection. The pattern is almost similar. Now suppose you first, as I had already discussed, we do first HBsAg. Okay. Three important tests are HBsAg, anti-HBc, and anti-HBs. Now, what does it signify? HBsAg means there is hepatitis B antigen is there. Okay, that surface antigen, that yellow colored part which I had discussed in first slide, that is there. Okay, so antigen means there is infection. Okay, anti-HBc means I told you chronic that core antigen is never seen. Only antibodies response can be seen. So if anti-HBc is there, HBsAg is there, definitely virus was there at some point in the body. Okay, so that is called a chronic hepatitis B. We need additional testing and management for that. Okay. Now, if patient has anti-HBc and anti-HBs, anti-HBc means virus was sometime there. Okay. So if their antigen is negative, but anti-HBs antibody is there for against S antigen, that means that body has suppressed this. Okay, virus successfully. So in past their virus was there, but now it is resolved. Anti-HBs is a very good marker. Okay. So successfully body has resolved this infection. Anti-HBs has become positive. Okay. Third scenario is patient has anti-HBc, but anti-HBs is not there, and HBs antigen. Both antigen and antibody are not there against S. This means there was past infection which has resolved, but anti-HBs is not yet formed. Antigen has gone, but antibodies are yet to come. Okay. So maybe sooner or later they might come. Okay. So that again signifies past infection which has resolved. Now, if patient has no anti-HBc and HBs antigen is also negative, but anti-HBs is there, this means this person is vaccinated because the vaccine contains HBs antigen particles and body mounts the anti-HBs response. So anti-HBs positive means we have immunity against hepatitis B, and anti-HBc negative means we never had the virus. So that can only come through a vaccine. Okay, we have immunity, but we never had the virus. So we have been vaccinated. That is what it means. Okay, and if all three are negative means we are not infected and we never had the vaccination. Okay, so in those cases we should vaccinate. Now, what is chronic hepatitis B? When we use the term chronic hepatitis B, it means HBsAg has been present for 6 months at least. DNA varies from undetectable to several billion. E antigen can be positive or negative. If E antigen is positive, then DNA levels have to be more than 20,000 to call hepatitis B. And if it is negative, it has to be between 2,000 and 20,000 to call it hepatitis B, chronic. Okay. ALT can be normal or elevated, and liver biopsy may show chronic hepatitis with variable stages of inflammation and fibrosis. Immune tolerant phase, it's just a repetition. E antigen is still positive, HBsAg is still positive for more than 6 months, DNA is quite high. But immune tolerance means a lot of virus is there, but there is no immune response, no inflammation. So ALT is normal, liver biopsy is normal. Active phase, immune active phase means we have mounted an immune response, ALT is high, liver biopsy is positive, still virus is there, which has been going on for last at least 6 months. Inactive carrier stage means we have mounted a good response, hepatitis B may be still positive, but E antigen, there is no other antigen. HBsAg will always be there, but E antigen is not there. Antibodies against E antigen has formed, there is seroconverted, and DNA is less than 2,000, DNA is suppressed, ALT is normalized, and liver biopsy will show various stages of fibrosis, but there will be no inflammation. Reactivation means previously there was HBsAg positive, okay, and anti-HBc was positive. but DNA was low. Now it has become high again, okay, as compared to baseline. So it means it has again become active, okay. So reverse seroconversion occurs. So if a person was HBsAg negative, anti-HBs positive, it had a good response, but still there was some occult infection going on, and now HBs antibodies are gone, antigen has come back. That also means reactivation. And flare, hepatitis flare means ALT is increased more than 3 times, or it is more than 100. That's all. That is a flare. Okay. Now, what do we do about it? Hepatitis B antigen positive means next step is to see for hepatitis E antigen. Okay. S antigen will always be positive now. E antigen, if it is positive, which means patient may be either in immune tolerant phase or immune clearance phase. Okay. If patient is in immune clearance phase, his ALT will be high. So next logical step is to look for ALT. If ALT is more than 2 times, ULN means upper limit of normal. So which is 25 for females and 35 for males. Okay. So if it is more than 70 for males and more than 50 for females, ALT, then you should look for DNA. If DNA is more than 20,000, directly go ahead and treat the patient. Okay. If DNA is less than 20,000, then we need monitoring. If ALT is normal, okay, or if ALT is less than 2 times from normal, but more than normal, then in that scenario, we have to monitor. We don't need to treat the patient. Okay. So this purple means treat the patient, that is HBs antigen is positive, E antigen is positive, ALT is more than 2 times, DNA is more than 20,000, go ahead and treat. Other cases, just follow up. Follow up is done by assessing liver disease, liver fibrosis and inflammation via ALT. Okay. ALT rises or patient develops more than F2 fibrosis that we had discussed in fibroscan, we see the reading, or maybe liver biopsy we can do to check for that. Okay. A3 means activity, 3rd grade at least. Okay. But is more than that, we may have to consider for treatment. Okay. Especially in people who are more than 40 years of age. Now suppose we do HBsAg which is positive, but HBe antigen is negative. In that case, look for ALT. Patient may be in immune active phase. Okay. In that case, if ALT is more than 2 times upper limit of normal and DNA is more than 2000, go ahead and treat. If DNA is less than 2000, okay, or ALT is between upper limit of normal and less than 2 times upper limit of normal, then just follow up every 3 months, okay, for 1 year and look for fibrosis and activity. If it is high, go ahead and treat the patient. Now how do we treat the patient? We can treat using, we have nucleoside and nucleotide antivirals, okay, inhibitors. So entecavir, which can affect the translation, okay, tenofovir, entecavir, adifovir, lamivudine. Okay, these are the drugs which can cause DNA minus strand synthesis or DNA positive strand synthesis. They can stop at this level, this replication, or they can stop at initial translation stage. Okay, only entecavir can do that. Other drugs, they're not being successfully in the market. Okay, they have been studied, but they have failed the trials. Now, PEG interferon alpha 2A. It is a drug which has been used since many decades. Okay, what does is it acts to boost up your immune response, and we mount a very good response against virus, and we can literally try and cure the body of this hepatitis B virus. Okay, but it comes with a lot of side effects. Okay, it is a finite treatment. Okay, around a year the treatment is given. Okay, and we can mount a good response against the virus, but it comes at the cost of flu-like symptoms, fatigue, mood disturbances, cytopenias, autoimmune disorders, anorexia, weight loss. All these problems are associated with it. Okay, there is a chance we may get rid of the virus, and there is a good chance we may not get rid of the virus. Okay, but in case of other drugs like entecavir, tenofovir, and tenofovir alafenamide, tenofovir alafenamide is the latest drug. Okay, which is given 25 milligrams daily, entecavir 0.5 daily, and tenofovir 300 milligrams daily. Okay, these are the oral drugs. Okay, PEG interferon is subcutaneous, but others are oral drugs. Okay, these oral drugs, they mount a very good response. Okay, they come with minimum or least of the side effects, But this is sort of an infinite treatment. There is very less chance we may be able to stop the drugs. Okay. So anti-GABA can, the side effect is lactic acidosis, which can come, which occurs in people with decompensated cirrhosis. Tenofovir comes with nephropathy, Fanconi syndrome, osteomalacia, lactic acidosis. Whereas tenofovir alafenamide, it is an advanced drug which is thought that it does not cause any renal dysfunction or any bone disorders. So no nephropathy, no osteomalacia. Lactic acidosis may occur. So it is the safest drug in the market, tenofovir alafenamide. Now, lamivudine, adifovir and telbivudine, they are not preferred drugs. Okay, they have some side effects, and virus develops resistance over time with these drugs. Okay, so that is why they are not in routine use. This is a chart depicting what is the suppose a patient is HBe antigen positive and we are using peg interferon or anti-GABA or tenofovir alafenamide. Okay, so the percentage of HBV DNA suppression is maximum with tenofovir based drugs, both alafenamide or plain tenofovir, rather than anti-GABA or peg interferon. Okay, HBe antigen loss is seen in peg interferon based drugs. Seroconversion is more in peg interferon because we are trying to get our body rid of the virus. So body is getting seroconverted. Immune response is very strong. So normalization of ALTs may or may not occur, but seroconversion occurs. HBs antigen loss is maximum, that is 11% after 3 years of treatment with peg interferons. No other drug gives that much this thing. HBs AG loss is seen with 8% in tenofovir and anti-GABA 4 to 5%, alafenamide only 1%. So we may never get rid of HBsAg positive status, but the virus can be checked under control with these drugs. Okay, and final duration of treatment is still unknown if we don't respond that well. Okay, HBe antigen negative, fairly good number of people will have DNA suppression with anti-GABA tenofovir and tenofovir alafenamide, like more than 90%. Okay, now ALT will normalize in most of the patients, but HBs antigen may not be lost. Okay, HBs antigen loss means cure. So only peg interferon gives a 4% chance of HBsAg loss. No other drug gives that chance. Suppose patient is HIV and HBV co-infected. So all such patients have to be treated with hepatitis B antiviral, specifically which acts against both HIV and HBV. At least 2 such drugs should be there in the regimen. So that ART regimen should include 2 drugs with activity against hepatitis B, like tenofovir plus lamivudine or amtricitabine. Suppose a patient is on immunosuppressive therapy, okay, and HBs AG and anti-HBC total should be checked in all such patients who we are thinking of starting immunosuppressive therapy and they are not on the drugs, they are not on any antivirals. Such patients who turn up as HBs AG positive and anti-HBC positive, this determines there has been chronic infection. They have to be treated with antivirals before starting chemotherapy regimen. Suppose anti-HBC is positive and HBsAg is negative, that may determine patient may have an occult infection, in which case routine immunotherapy drugs can be given, but anti-CD20 antibody therapy, that is rituximab, and people going on stem cell transplantation, only those 2 are the conditions we have to treat them. Otherwise, no treatment is required. Suppose when indicated, HBV prophylaxis has to be started as soon as possible, or at least simultaneously with the onset of immunosuppressive therapy. Okay, and it has to be continued for at least 6 months till the therapy is over. Okay, anti-HBV drugs with a high barrier of resistance, that is anti-GABA tenofovir or tenofovir alafenamide, should be preferred in such scenarios. And suppose you choose just to monitor HBV DNA and not give the prophylaxis, in that case it has to be done at every 1 to 3 months, which is quite costly. Suppose a woman is pregnant and she is HBsAg positive. In her first trimester, we have to look for all hepatic panels. That is, LFT has to be done, platelets, INR, HBC antibody, HBs antibody, HBe antigen, HBC antibody, and HBV DNA quantified. Okay, if there is active disease, okay, then, or there is cirrhosis per se, okay, then we may consider her for treatment. Okay, if treatment is not indicated right away, then at the end of second trimester, we should look for ALT and HBV DNA. And if there is a previous child with HBV positive status, to that female, then regardless of any maternal HBV DNA level, we have to treat that lady in third trimester. Okay. Suppose there is no previous child, or child is negative for hepatitis B, even if it is there. Then if the DNA level is more than 10 to the power 7, that is more than 1 crore copies per ml, in that case only we have to start treatment with lamivudine or tenofovir, which has to be started in the third trimester, not before that. And we may consider stopping in the postpartum period. Okay. If HBV DNA is less than 1 crore copies per ml, then we just have to monitor it, no need for treatment. In children, interferon alpha 2b is approved for children with 1 year or more than that. Treatment with anticavir is associated with low risk of resistance as compared with lamivudine. Tenofovir is not approved for children below 12 years of age. More than that, we can give them. And tenofovir alafenamide is not approved for 12 years or more. Okay, only after 18 years we can give. Suppose the person is lamivudine resistant, treatment is tenofovir. Telbivudine resistance, again tenofovir. Adifovir resistance, again is tenofovir or anticavir. If anticavir resistance, again tenofovir. Tenofovir resistance is there, then anticavir can be given. Or multi-drug resistance, then again tenofovir. So except tenofovir resistance, all other scenarios of any resistance, tenofovir is the drug of choice. Okay. In tenofovir resistance, anticavir is the drug of choice. Suppose you get exposed to a hepatitis B positive person by a needle prick, or a mucocutaneous exposure is there with a positive blood. In that case, if you're unvaccinated, then hepatitis B immunoglobulin has to be given, administered to you at the dose of 0.06 ml per kg, and initiate the hepatitis B vaccination series, that is 0, 1 and 6 months. Okay. Suppose you are vaccinated previously, then you should know that are you a responder or a non-responder. A responder means that you have anti-HBs titer of more than equal to 10. Okay. So if you have that, no, don't worry, you won't get the infection. If you have titers of less than 10, then you might develop an infection. So you have to take hepatitis B immunoglobulin, that is 2 doses 1 month apart, or 1 dose, and then start the vaccination schedule. If you don't know your antibody response, or is it unavailable in your region, then you have to test for anti-HBs. There is no other way. Okay. If it is adequate, then it's okay. If inadequate, then hepatitis B immunoglobulin followed by vaccination. Thank you all. Special thanks to the Pharm D for the effort. I think that's all from my side. Any questions I can take?
Yes, sir. Thank you, sir, for such an informative session. So the participants have posted a few questions. Can we take it up?
Yeah, please.
Okay. What are the precautions to be taken after hepatitis infection?
See, hepatitis B infection, universal precautions have to be taken. Okay. As in, you are asking that if you are infected with hepatitis B, then you cannot donate blood. Okay. You have to take it back. You have to get your regular checkups, regular treatment. Okay. If you are starting on antivirals, do not switch between the drugs. Okay. Unless your doctor suggests so. Do not change the company, even company of the drug. Okay. Because each drug is different. Okay. Even each company makes a different sort of drug. Okay. I will suggest, so do not donate, do not switch between the drugs. If drugs are not, you have not started on any drug, then you have to consult your physician or a hepatologist or a gastroenterologist whether you are indicated for any treatment or not, and whatever monitoring has to be done and whatever intervals it has to be done, you have to follow that strictly. Otherwise, you may end up having cirrhosis, or which can be decomposed, or you can develop a hepatocellular carcinoma. Okay, under strict monitoring, you have to be there. So if you are planning to you develop some new illness, suppose some cancer of some sort, and you are starting immunosuppressive therapy, or some immune diseases which need immunosuppressive therapy, in that case, you have to get your hepatitis B checkup done. Okay, if DNA is, if you are positive, then you have to start your treatment. Nonetheless, whatever DNA you have, or whatever immune response you have. In case of hepatitis C, if you are already cured of hepatitis C, there is no need for rechecking for hepatitis C RNA unless you develop any abnormality in your liver.
Yes, sir. Another question is, what is the actual mechanism of how IV drug use causes viral hepatitis, provided if they use sterilized needles?
See, if they are sterilized and used, see, earlier we used to use glass syringes, okay, and they were reused, okay. So even after proper sterilization, it was there was small risk of getting, because there are some small holes, okay. The sterilizing solution doesn't go into that, okay. So the virus may still be lying there dormant, okay, and when you use it, you may infect the other person. So in older times, when the syringes were glass syringes and they were reusable syringes, that time it used to happen that exposure was there, or with the blades, which people in the barber shop and all those places use blades which are reused. In those cases, you can develop infection. But in sterile syringes, okay, there is minimum chance or no chance you can develop an infection nowadays. Okay, needle stick exposure, unless patient is positive, you have to be careful during surgeries, especially. Okay, but otherwise, minimal chance nowadays. Most common mode of exposure is parent-to-child transmission in our country.
Yes, sir. Another question is, what is the role and function of monoclonal antibodies in the treatment of hepatitis C, and how to improve the therapeutic efficacy?
Monoclonal antibodies are not used in management of hepatitis C, as in
Uh,
no approved therapy with monoclonal antibodies.
okay,
Only
sir.
latest direct acting antivirals and the regimens which I've already explained, but there is no role of any monoclonal antibodies in hepatitis C. Suppose you are getting monoclonal antibodies for some other disease and you are having hepatitis C already. Okay. In that case, you can check yourself for a hepatitis C RNA levels. If it is negative, then no need for any repeat therapy. If it is positive, you have to get that treated first, then only you can use monoclonal antibodies. But monoclonal antibodies for hepatitis C is not there. There is nothing like that.
Okay, sir. Another question is hepatitis in pediatric patients, like how to manage.
See, hepatitis in pediatric patients, there are a lot of causes for having hepatitis. Hepatitis, by hepatitis, if you mean hepatitis B and C and any other elevation in ALT, AST, there are n number of reasons which can happen, and we have to evaluate for that, especially in children's. Okay. Most common is drug induced. Okay, some antibiotic has been given which can cause rise in ALT, AST, and which has to be just if the drug can be stopped for some time, a few weeks, and then again we check it, it will be normal. Okay, but suppose you have hepatitis B or C in a child, okay, which is the topic today, relevant topic. Then in that scenario, I have already mentioned that it has to be, hepatitis C has to be treated, whatever the sort of infection you have, and less than, if it is child is less than 3 years, we have to wait the child to become 3 years of age, and in case of genotype 1, 4, 5, and 6, we can treat with sofosbuvir and ledipasvir. If it is the child is genotype 2 or 3 infected child, then we have to wait till 6 years, and after 6 years, we have FDA approved drugs, sofosbuvir and ledipasvir, which we can use in children. Okay, which can be obviously weight-based regimens, but it can be used. For hepatitis B, more than 1 year, we have peg interferons, but they come with side effects. But more than 3 years, we have anticavir. So basically, we can use anticavir easily in children. Okay, for the hepatitis part. So this is more or less the regimen in children. Some other virus, some other illnesses which occur in children, like cholestatic hepatitis occurs, Wilson disease. Okay, so non-cirrhotic portal fibrosis. There's so many conditions which can cause hepatitis in children. So it has to be evaluated. Without evaluation, you cannot treat that.
Last question, sir. What is, like, in COVID and hepatitis? What is the correlation now?
See, yeah, I have reviewed 4 or 5 papers with COVID and hepatitis. See, COVID, there is hepatitis in COVID. Okay, it has been seen that SGOT and SGPT, even to some extent bilirubin, it rises marginally in hepatitis or in COVID infection. Okay, but that is not that significant. We don't need to run after it. We don't need to worry about it. Okay, there is no specific treatment in that scenario. Just management of underlying primary disease, that is COVID, is more than enough. Okay. Having said that, there are drugs like remdesivir, which is used in COVID infection, and even sometimes HCQ. These have been found to be associated with transient elevation of AST and ALT, which determine hepatitis. And the elevation in hepatitis, the AST-ALT may be just due to the drugs which we are using and not because of the COVID infection per se. So it is nothing to be worried about. It has been seen that AST-ALT rises, some to some extent bilirubin rises, but no change in the treatment is required regarding that. Okay. Second thing, if a person is hepatitis B and C, the treatment regimen goes same. Okay, there is no change in the treatment as even if he gets a COVID infection. There is no change really. Next question.
Yes, sir. Another question is, if a person having HBs AG positive and wants to get married, we don't know whether the wife has taken the vaccine or not. So, what can happen in this
What
case?
we have to honestly ask the wife to get an HBs antigen or HBs antibody checkup done. Okay, that is called anti-HBs. Okay, if anti-HBs is positive, okay, that is more than 10, maybe more than 100. Okay, so that means she has been either she has gotten the exposure before or she has been vaccinated before and she has been cured of it. Okay, if and she is very sure that she has never been vaccinated and anti-HBs is negative for her, okay, then we have to vaccinate her before they can start their married life. Okay, the vaccination schedule has to be completed. Okay, otherwise they have to use a physical barrier. Protection has to be used so that the person doesn't transfer infection to her spouse or his spouse. Okay, so anti-HBs is the first step, and if anti-HBs is positive, well and good. If it is negative, then get hepatitis B vaccines, and then you can start your married life.
Yes, sir. Last question: can hepatitis be caused due to menstrual unhygiene?
Can you repeat that question, please?
Can hepatitis be caused due to menstrual unhygiene?
No, it cannot be caused unless there is exchange of body fluids. It cannot be caused. That exchange can happen via sexual transmission, or via parent to child, or by IV drug abuse and whatever mode of transmission we have discussed. But menstrual unhygiene or any sort of unhygiene cannot cause hepatitis B infection.
Yes, one more. Do scarring of the liver be recovered after the treatment of hepatitis C?
Yes, it has been seen that we have taken care of the cause of the liver scarring. Okay, that is hepatitis C has been cured. In that scenario, to some extent, it can be sometimes it may be it may not be completely irreversible. It may be somewhat reversible. So either it halts there, or it can be reverted back. Okay, there is no exact data that how many patients will revert back, how many patients will go on to develop further cirrhosis and decompensation, but monitoring has to be continued. Okay, we don't really know it, but definitely people have seen F4 F fibrosis to convert to F3 and F2. F2 to F3 has converted to F1. So it has been seen. Okay, it has been reported as well, but there is no justification that we are not following up the patient. Just because we have treated the patient and patient has cirrhosis, there is no justification of no follow-up. Patient has to be routinely followed as usual on cirrhosis guidelines, irrespective of treatment. Okay.
Yes, sir. Chronic inflammation of liver can lead to cognitive problems where patients become tired, have poorer memory, and
Yes.
so the reduced response time. What can we do to tackle this?
See, that we are discussing is patient developing cirrhosis and some sort of hepatic encephalopathy. Okay, it can be a chronic hepatic encephalopathy. It can be an intermittent hepatic encephalopathy. It can be an acute hepatic encephalopathy. There's encephalopathy. By the encephalopathy, you mean that tiredness, slowing, forgetting something, memory loss. Okay, more of sleeping during daytime, all these things. So this can be controlled very easily by simple methods like patient's motion as to syrup lactulose. Okay, that is one treatment regimen which can take care of these things, and rifaximin therapy. Okay, it is an oral drug which can take care of these problems. Okay, it is all because of gut microbiota translocation. So if we take care of that, we can prevent patient going into encephalopathy and causing these problems. So this can be taken care by lactulose, the most successful therapy, and rifaximin, the second successful therapy. If we take care of these two things, we can even revert or prevent patient from going into recurrent encephalopathy. So lactulose and rifaximin are the most promising therapies, other than the treatment which is going on already.
What other organs can hepatitis affect?
Hepatitis most commonly affects liver. Okay. If we talk about hepatitis C, we have already discussed that it can cause nephropathy, it can cause non-Hodgkin's lymphoma, it can cause cryoglobulinemia. Okay. It is associated with thyroid cancers, renal cancers, okay, polyarthritis, diabetes, and lichen planus. So these things are associated with hepatitis C. Hepatitis B is associated with glomerulonephritis, okay, again non-Hodgkin's lymphoma and polyarthritis, okay. So kidney, liver, skin, and blood, I can say, as in these things can be affected by hepatitis. Most common is liver.
Yes, one more. How to monitor patient post hepatitis C seroconversion?
Yeah, so we have to look for SVR, that is sustained virological response, which is a quantitative RNA, which is done after 12 weeks of completion of therapy. Okay, so if that is completed done, there is no further monitoring required, because if patient has achieved that, there is a fairly good chance he may not develop the reinfection, okay, or a reactivation. So that is, we don't need to repeatedly monitor it. If SVR is achieved, that's the end of story.
Yes, Yamini, can you take over?
Now we end our question and answer session. The session was really informative, sir. Thank you for such an enlightening session. It really provided an in-depth knowledge about management and pharmacotherapy for hepatitis.
Most welcome.
We appreciate having our participants' doubt clear. Thank you very much, sir.
Most welcome.
We would also like to have such informative sessions with you in future.
Sure.
I also would like to thank all the participants to take out their time for the webinar. We hope the session was informative and useful for you and would prove useful for you during your clinical postings. To stay updated regarding our future webinars, you can join our Telegram group through the link for Telegram group, which is posted in the chat box. I would also request the participants to now fill the feedback form for this webinar. Thank you.
Yes, sir.
Thank you so much, sir. And I'm sorry for the network issues that took place in the earlier part of the session, in the starting of the session. Hoping for more webinars like along with you in the future too.
Sure. Okay. I can leave now, no?
Yes, sir. Yeah. Thank you so much, sir, once again.
Most welcome.